Okay. Hi, everyone. Thank you all for attending this webinar. It's called Accessing Mental Health Care, Boundaries, Current Therapy Practices, and Ways to Get Help, presented by the Hamilton-Wenham Human Rights Coalition. I'm Maya Beach, and I will be moderating today's webinar. I'm a teenage girl who's half East Asian, half white, with shoulder-length black hair and dark brown eyes. Today, I'm wearing a white t-shirt and sitting in front of my houseplants, assorted art, and a light blue wall. Before we begin, I wanted to thank our ASL interpreters, Jody and Ashley, for being here and providing ASL interpretation. Live Zoom transcription is also enabled. The audio and video for this webinar is being recorded and will be posted to our public YouTube channel. To participants, please keep your camera off to help us record our video. If you have any questions, please privately message myself or Olivia. Lastly, HWHRC would like to begin by acknowledging the Massachusetts tribe, the tribe of Indigenous peoples from whom the colony, province, and Commonwealth of Massachusetts have taken their name. We would like to pay our respects to the ancestral bloodline of the Massachusetts tribe and their descendants who still inhabit historical Massachusetts tribe territories to this day. Okay, to get started, I'm happy to introduce our first panelist, Dr. Yvonne Bissing, who will talk about boundaries to mental health care and stigma around mental health.
Good afternoon. Thank you for having me to come and talk about this very important topic. I have a PowerPoint that I'm going to show, and so I will set that up for you right now. As a background, I am the founder and director of the Center for Child Studies at Salem State University, and I am on the Human Rights panel for the American Association for the Advancement of Science. And I do work with Human Rights Educators USA. And I am the US Child Rights Policy Chair for the UN Convention on the Rights of the Child, which is the human rights treaty supporting children, of which all of the UN countries have ratified except for one, and that's the United States. So today I would like to talk to you about student mental health. I have a postdoctoral degree from the National Institute of Mental Health. I've been a therapist. I'm a trainer for NAMI, the National Alliance of Mental Illness, in their family to family class, which is a really wonderful and free class that any family member can take. So I would encourage you to check out that program. So before we start, I just want to do a few quick definitions. And I'll be talking about children. And children are defined by the UN as anyone under 18. And that's the international term. And young people around the world, 17 and below, all find that to be a rights respectful term and a high status one, instead of talking about the way we look at children here of, oh, I'm just a child. No, they're very important. And children are entitled to rights, including the treatment. And this means that we have to be careful about the words, ideologies, policies, our actions. Now, we as adults, teachers, parents, are duty bearers who are obligated to ensure that children's entitlement to human rights are protected, like good mental health. And we're talking today about how we're going to try to achieve the best interest of the child. And that should always be the number one thing that guides our decisions. And it will focus on equality, inclusion, and justice. So I have a set of slides of pictures here of different faces of people who have wild eyes, and the caption is "Children learn, don't be crazy." And even if you are a preschooler, a toddler, children learn about the negative aspects of having mental illness. And we find it true in conversations with mom and dad, we see it on TV, our friends, cartoons. So we have to be aware that even very young children are already learning that it's not okay to have mental illness. There are all kinds of stigmatized words that surround children around mental illness, like you're crazy, you're insane, you're psycho, you are Looney Tunes, crazy as a bedbug, squirrely, cuckoo, demented, off your rocker. We have all kinds of words that children hear and use on a regular basis. And we need to be very cautious about how we speak about one another. We all have bad days, but talking about people being crazy in a stigmatized way role models bad learning for them. Now, I've got a series of triangle diagrams that I will be showing today. And one I have up now is from teenmentalhealth.org. And it talks about how we have to use the right words when we're talking about mental health, especially around young people. At the bottom of this triangle or pyramid, we have a big area of no distress, no problem, no disorder. And this is the ideal. And most days, this is where we all operate. Things are going along hunky-dory. We are having a good day at work, at school, in our families. We have enough to eat. Everything's pretty much okay. All right. As we move up the triangle, the next level is on mental distress. And we all have those. We get stressed out about a test coming up, about company coming, about somebody being angry at us. Hans Selye, a researcher, talks about eustress and distress. And we think of stress usually as being distress, like something bad is going to happen and I'm all upset about it. But it could also be eustress as a good stress. Like I have a date with this person I've been waiting to go out with, or I've got an interview for a job, or something wonderful is going to happen. I'm having a party and people are going to come and you get excited about it. It's stress, but it's good stress. But nonetheless, our heart rate goes up and we get excited. Now, that's all normal. As we go up the triangle, the next rung is on mental health problems. And again, we all have them. Grandma dies. We get sick. Someone has COVID. The car crashes. There's a fire. Something bad happens. And these are normal life occurrences. We hope that they don't happen, but they always do. So the issue is that how do we handle those kind of mental health problems? So on the bottom three rungs of our triangle, it's normal behavior. And children can learn the differences between having no distress, mental distress, having a mental health problem. And these are different than having mental illness or a mental disorder. And a lot of times I think we talk about the bottom rungs as being all mental illness when they're really natural coping issues for us to learn how to develop a skill set to handle. So in short, mental illness or mental distress is so common that it's normal. Everybody experiences mental health problems sometimes. Mental illness does exist, but it's often misdiagnosed, especially in young people. When people have different kind of behavior, often folks don't know how to respond to it. But we need to know that help exists and help matters. But for young people, it's really hard for them to find help. How do they access it, get to it, transportation, get parental consent? How are they going to pay for it? All of these things are very difficult. So today, everybody will be learning some information and resources that I hope will help us to be able to better respond. The next slide has a picture of hear no evil, see no evil, speak no evil. And we know that when people see someone having a behavior, we may not identify it as being mental illness. Okay, people may try to talk to us. One thing I've learned is that people always tell you things that matter to them. They don't talk about things that don't matter, right? And so if they're talking about something that happened at school or a fight with a friend, that means that that was an emotionally significant event for them. So we better pay attention. A lot of times, children don't tell us what's going on. They hide it. And we as adults often pretend that we don't see it. We're busy. We've got a lot of our minds, and it's very difficult to always pick it out. If you think of what it's like to be 12 or 13, you've got peer relationships that are big. Your body is changing. You're going through hormones. You've got family issues. You're trying to assert your independence. There are so many things going on. It's easy to ignore or to think that something's happening that isn't mental illness. We need to pay attention. Another issue is we've got this mind-body relationship going down. And so we know that when we get upset about something, we get emotionally upset, then often we get a bellyache, we get a headache, we just don't feel good, we want to go to bed. Okay. Likewise, if we get physically sick, we've got a flu, a bug, that we will start to get emotionally upset, and we may snap at people or cry and have a behavior that's different than we would normally. So what causes what? You see, we have a cause and effect relationship, and often we don't know, right? People tend to pay more attention to physical ailments and really don't put the same degree of attention on mental well-being. But we know that mental disorders can be more disabling than many chronic physical illnesses. Here's a chart on mental health facts for children and teens. And it's got data that says 1 in 5 children age 13 to 18 will have a serious mental illness, and that they will have mood disorders, a conduct or behavior disorder, anxiety, depression. That we will see that half of the cases of mental illness begin by the age of 14. Okay, I think actually it's bigger or younger than that. We don't collect data on children and mental illness who are 6 or 7, but we now know from seeing all the reports, especially during COVID, that many children are having, even in preschool and toddlers, having emotional response. So we need to be aware that mental illness isn't something that just creeps up and gets you when you're big. It starts when you're young, but it's typically 10 years before people get help. All right. We know that students with mental disorders tend to drop out of school. They have more contact with the criminal justice community. And unfortunately, suicidal ideation. Suicide is the second leading cause of death in young people. And that is just a stunning statistic that we need to pay attention to. If we look, as another chart with a brain, and it says that basically most of the students get no education on mental health when they are in high school. And then when they get into college, a lot of times they're on their own for the first time, and they're having a very difficult time trying to adjust with all the new coping skills. That fewer than 10% ever tell people that they're having mental illness. Maybe they don't know, they don't identify it as that. Maybe they think what they're feeling is quite normal. Maybe they're scared that they're going to get in trouble, so they don't tell anybody. Maybe they're afraid that there's going to be some sort of punishment or retaliation if they do say. The stigma, again, of being crazy is so prominent for them. We find 1 in 3 students have depression. 1 in 4 report having suicidal thoughts or feelings sometime. The third end up having trouble with their schoolwork and performing. So we have to pay attention. We know that the majority of students, whether we're talking about middle school, high school, or college, have a hard time doing their schoolwork when they are feeling overwhelmed or depressed. All right. The use of psychoactive medication is excessive in American students. And sometimes being on the right medication is absolutely needed and warranted, and it can be a life-changing benefit. Other times, people get on the wrong medication and they are not being worked up properly. My feeling is that if you're going to put a child on medication, you really want them worked up by a psychiatrist or someone who is a brain specialist with a great deal of knowledge about it. Going to a nurse practitioner, as wonderful as they are, they don't have that kind of skill set. And we know that many drugs like Celexa can actually trigger suicidal thoughts for children. So we want to be very careful about this. Here's another triangle, and this one is from the Centers for Disease Control, and they're looking at what's called ACEs, or Adverse Child Experiences. And they find that what happens early in life has a lifelong impact. So they are collecting blood data, hormone data, all kinds of physiological as well as emotional data, and finding that even babies like 3 months old will have differences in their rankings compared to children who are not stressed. All right, so we want to think that, oh, that stress doesn't matter. Oh, yeah, it does. So we're talking about poverty. We're talking about families fighting and mom and dad having economic trouble, and people moving in with you, and brothers and sisters fighting with you, substance abuse in the family, someone has to go to jail. All of these things are very disruptive to a child. As you go up this pyramid, they find that the more ACEs, or adverse experiences, you have, the higher probability that you're going to have your own emotional problems, social problems, and physical as well as mental health problems. They're indicating that people die early. So addressing the trauma, especially toxic trauma that occurs in childhood, is super important for us. We need to get in touch with children's reality. We need to talk to them. That they're going through hard times and we may not know. So we must be attentive and look for signs. They need to know that they are not alone and that other people have similar kinds of problems and are able to overcome them. Students need to know about resources and how to find them. Many times all they know to do is maybe talk to their pediatrician or the school counselor. And we know that on average, there's 250 students per counselor. All right, everybody needs a counselor, in my opinion, for at least some time, right? And so if you're having a crisis at school, then you need help, and you probably need it then, not, later on. So students may not want their family to know that they're having problems. And indeed, families could be part of the problem. If you've got a child who's being abused or sexually exploited, then mom and dad may not want that child to report. And so it is important to be supportive and listen to them. All right. So let's make sure we can try to get the students to know that there is help and how to access it. Here's the third triangle for us for the day, and it's looking at how we can help students with support. And at the bottom, if we have safe, stable, nurturing families in communities that care, that's a great starting point. And I must tell you that on this pretty Saturday in the summer, I'm happy to be with you because you care as a community. You are providing this kind of very foundational support for your students. And I must congratulate you, how lucky your students are. We need to have skilled child savvy workforce. Parents need peer counseling too. Most parents don't know how to be a parent. They parent the way that their parents were parented. If their parents did a good job, then they probably do a better job. But somehow giving students those egg babies or whatever in health class doesn't quite cut it in terms of how to learn how to be a good parent. We need student support services that are there at the school that they can access immediately. Real counselors, not the police officer. All right. They may have their role, but we need counselors there who are trained to work with students. We also need to know who in the community we can refer to who really know how to work with children, and often testy families. Now, we know that during COVID, it was already a bad situation for student mental health, and it's only gotten worse. Remote learning was hard. They were isolated from their peers. It was hard for even the best teachers to be as supportive as they would like. Students got too much togetherness at home, and was it togetherness breeds contempt sometimes? That they may see domestic violence, parents arguing, child abuse, I believe, increased. Parents don't know how to be teachers, and hopefully they figured out that we have a skill set that they do not have, and it's really hard to be a good teacher. And we know that, and I hope that they have figured that out too. And some of them didn't do a very good job, and the students suffered from it. So we need to figure out how to help students. Here's another triangle for you, and it's a hierarchy of mental health needs. And it's got lots of colors, and we're looking at how do we give support, treatment, how do we give students good coping strategies, getting them enough sleep, getting them food. Free breakfast and free lunch really matter for students. Having relationships that we teach students on how to do. Conflict resolution. People do not know how to resolve conflict in a way that is constructive. So I've worked with teachers who really were intent about conflict resolution. When you have a conflict, it takes a lot of time to work with these two students to figure out the conflict. But the more that they learn the skills, the quicker they learn how to do their own conflict resolution on their own without adult intervention. And it's a lifelong, wonderful skill to have. Knowing how to laugh, how to have humor, to be empathy, we need hope. And this is what the hierarchy is focusing on. Now, I have just a few slides that I will go through briefly, but we're looking at depression and anxiety signs, and they tend to go together. And we know that the more stress, the more ACEs you have, the more risk factors a child has. And that depression is a serious, it can be life-threatening kind of condition. We need to get family patterns. We see that their hormone levels will be different. Summer sun is different than if you're inside in the winter. You've got chemical imbalances, especially for children going through puberty, or dealing with romance. You've got the exposure to different drugs and alcohol that's going down. They won't tell us because they may not know when they're having difficulty. They don't necessarily know what is normal from what's not. And so we have to look for signs. And this is why it's important to have one-to-one contact with it. I listened to the people talking about COVID and saying, well, we shouldn't have, so many students in a classroom. No, we know as teachers, we would do better with having 15 in our classroom. When you put 30 in a classroom, it's really hard to be attentive to each and every one. So in many ways, having small classes wouldn't be bad for any reason. It would be good for COVID. It would be good for the lack of transmission of disease. It would be good for us to be able to figure out their emotional and learning needs. If children are tired, they don't have too much energy, or they got too much energy, their eating patterns too much or too little, that they have aches and pains, they cry, they just aren't as attentive or as responsible, that they tend not to be as careful about their personal appearance. They move slower. They may seem sad, anxious, guilty, angry, mood swings, feeling of helplessness and hopelessness, being very sensitive to criticism. You might not even think you're saying anything mean to them, and that they fall apart because you said something bad about their paper. The self-criticism that we have, the tendency to believe that nobody loves me, nobody likes me, I don't have any friends. We can watch students avoid situations, find distress, maybe have panic attacks. They may have a lot of fears and worries. They may obsess about what happened in the past or what's going to happen in the future. They may feel like they're on edge, maybe be irritable. They can't decide. Their memory is compromised. I just can't make a decision. All of these are signs for us. We also need to be attentive to the students who self-hurt, and that cutting, burning themselves, hair pulling. There's a variety of ways that students will hurt themselves. They're not suicidal, but they are looking for ways to release some of the pain that they're carrying inside. So we need to, when we see this happen, discuss what is happening calmly. If you see those lines up a kid's wrist, then pay attention, ask questions. You don't threaten them, you don't scare them, you don't trivialize what's going on or try to punish them. Sometimes it's a fine line between when you call mom and dad, right? Because if a child is in trouble and you talk to mom and dad, we had a case where the student was suicidal, and you talk to the parent, they say, well, I'll just go kill them if they think like that. No, wrong answer. The parents were part of the problem. So you really have to be careful with when you are talking to parents and how you are talking to them and what kind of backup that you have. As teachers, what's not supportive is don't tell them just to snap out of it. We may try to joke, but they often don't think it's very funny. Don't be hostile or sarcastic. We must not blame them for whatever problem that they're having. We don't want to be helicopters, and get over involved and hover and smother. On the other hand, because we want them to be independent, but we need them to take responsibility too, and to engage in a dialogue and a conversation. Learning how to have dialogue is such an important skill set that I really hope that more schools will focus on. Don't trivialize their experience or feelings or belittle them. Don't patronize. Students hate that, right? And don't try to fix them or cure them. That is often not helpful. They may see it as a form of microaggression. Even well-intended people may say or do things that students see to be microaggressions. And then we may not understand why the students are all upset. I accidentally did this with a student who had disabilities, and I was going to help put them the leg braces on, and the student snapped at me and says, I can do it myself. It might have taken him longer, but by God, he could do it himself. And I didn't realize I was being condescending. So even well-intended assistance may not be. So we really need to have more understanding about especially students who have challenges. Be careful how you respond, because you can be a lifeline. Saying things like, I don't have time right now. Can we set up a time to talk? Well, I understand, but we might need to use that moment. Saying things of, wow, that's tough. I don't know how to respond. Let me refer you to the counselor. Right now, you are the counselor, right? And this is why I think teachers need more skill sets, or more arrows in our quiver that we can pull out to be able to assist students. Don't say things like, well, that happened to me once. No, it's not about you, right? be careful about fantasy and denial. You must ask them permission, if they've got troubles. May I go talk to, right? And if they say yes, okay. But if they say no, then be very careful. There are all kinds of really cool mental health resources, especially for students with depression, hyperbole and a half, the Don't Be a Dick movement, the Bring Change to Mind with Glenn Close, the Mental Illness Happy Hour. NAMI's got programs for young people. There are really good resources, and a lot of them are online. And the online resources may be very helpful, especially if you can't get students to a provider, and they don't want their parents to know. All right, so I'm happy to help you. If you ever need anything, let me know. Be compassionate in what you say, do, and think. Someone sent me a quote this morning that says, "Grief is our common bond. Opening to sorrow connects us with everyone, everywhere. Children carry extraordinary burdens, and so we can help them shoulder that." Thank you for the opportunity to talk to you, and let me know if I can help. Okay. Thanks very much.
This is Maya speaking. Thank you so much, Dr. Bissing, for discussing how words from adults, media, and peers contribute to the stigmatization of mental illness, the importance of the language we use to define our mental health, information regarding youth, mental health, illness, microaggressions, and trauma, including with COVID. You gave us resources as well, and also taught us the roles that we need to play in order to support students. Your expertise was greatly appreciated. Next, panelist Dr. Jesus Remigio will share about mental health care access for deaf and hard of hearing folks and cover what's working, what's not working, and how we can make mental health care more accessible.
Thank you, Maya. Thank you so much. Thank you. I want to make sure that we can make sure that we've got visual access for everybody. We do have 2 interpreters on the screen today. Both are wearing black, and you'll see them. I myself, Jesus, am here in a blue jacket with a pink bow tie and a dark background. Make sure everybody's got access. So I'm going to share my screen today, and I will provide descriptions for those as well. Thank you, Maya, for introducing me. Thank you so much. And thank you so much for your presentation about children and mental health in schools, Dr. Binning. So here we go. Great. Of course, like Maya just said, I'm going to talk a little bit today about mental health care for access for deaf and hard of hearing people. The opening slide has the title, and my name is listed underneath with my role as Associate Director of Student Services, and I work at Brown University. Moving on to the next slide here, I'm going to talk a little bit about what you're going to see today in my presentation. It's a brief agenda. There are 4 bulleted listed. First, I'll open with my background about who I am, my experience, and how I got here today. The next thing, I'm going to talk about a few scenarios or examples to help you really conceptualize and understand what mental health care looks like for deaf and hard of hearing and what barriers they may face. On the third bullet, we're going to talk a little bit more about how we can make sure that mental health care is accessible to deaf and hard of hearing individuals, making sure that they have equitable access as the mainstream community. And then the last bullet, we'll talk a little bit about resources, and I'll include my contact information for any contact post this presentation. I do want to add, you will notice that when I'm signing, the interpreter may carry on talking a little bit longer. And the reason is that ASL and English have different rules, different syntax. You may see I'm signing something fast and short and sweet, and the interpreter may need to add some things to that to make it understandable for the English language. All right, I will explain the picture on the slide that I just turned to. In the picture, you will see a Latinx gentleman with glasses and a purple bow tie and gray suit. I am standing in a courtyard in this picture. The reason I show this picture is that as a deaf person, we typically are going to talk about our background. Always. This is a hallmark of our culture. We are going to explain who we are. And you may be out in your field and run into a deaf person, and you may think and see they're talking about their life first and their background. You may ask them a question that you feel is simple, and they may give you their story. Just listen. They're telling you their journey and how they got to where they are today. That's, again, a hallmark of our culture. I worked for 6.5 years in a psychiatric unit as a program coordinator, communication specialist, deaf interpreter, consultant. I served many clients in my time there who were receiving mental health treatment, and that includes both deaf and hearing and children and adults. I work collaboratively with social workers, doctors, nurses, interpreters, etc., all in the unit. And I'm going to share today a little bit of what I've noticed and gained an experience. So, for example, when we talk about American Sign Language interpreters, hearing, and then deaf interpreters are a native language user who are culturally and linguistically competent. It's their native language, their native culture. And when they work with a deaf person, they're going to work in conjunction with a hearing interpreter. Right now, where I work is at Brown University. I've been there about 1.5 years ago, and it's been an honor to become a part of the Brown University family. I'm the Associate Director of Student Accessibility Services. I make sure students have access throughout a variety of departments at Brown University, and the ultimate goal is to provide students with equitable access to everything Brown University has to offer. You may be listening to me talk a little bit about my background and how I got here, but again, that is a hallmark of our culture. So hopefully you can conceptualize a little bit more about who I am today. Sound good? Great. Moving on to the next slide. I'm going to share a few scenarios today. I'm going to make sure that I keep things short and sweet. During my time working in a psychiatric unit, there was quite a few things that I noticed that really had an impact on me. So when I explain this scenario, I'd like you to just sit back and really visualize what this looks like. So in this, we've got a clinician who has never worked with a deaf or hard of hearing person, does not have information about the culture of the language, and they may call upon a hearing interpreter. This interpreter for this scenario does not have experience working in mental health environments. And so these two providers are going to go in to a patient who was recently admitted. This is a new patient to the unit, and their language is not ASL proficient. They may rely on gestures, and they may experience some frustration. The hearing interpreter may be struggling during the assessment, and the clinician may be doing their best to assess and take notes. In this situation, what happens later during perhaps a wraparound meeting or consultation, they may start to talk about what they observed. And the clinician may say, yes, I did notice that this person was responding to internal stimuli, and I saw that they were actually talking and engaging with a person off to the side. I noticed that they would look to the floor frequently, or they would look up to one side, and they must have been talking to somebody. As a deaf person, I find that interesting. The hearing interpreter would say, yes, I understand this person clear, and I really felt like I understood what they were saying. And so if we can pause in the scenario and back up a little bit. When we talk about what was observed in the patient when they arrived on the unit, we need to separate two things here. First is that if a deaf person grew up with parents who were ASL users, and they're describing a scenario, they may use space to be able to share a story, which means they may move their eye gaze up or down, talking about an experience with their parents, the parent being positioned higher in space than the child. And so the clinician may think that person's looking up or looking down, and they are hearing voices. But this is separate from what we actually know of ASL linguistic proficiency, which is separate from a symptom or from responding to internal stimuli. So now with that situation, we have to explain to the clinician and say, wait, we need to work together. Me as a deaf consultant, you may have taken notes and even led to a diagnosis that were inaccurate because of the lack of cultural linguistic competency. We don't for sure know what this person's communication development looked like or their language development. I would like to emphasize it's important here that we remember that interpreters should not try and fix what the patient is trying to say or clean up their language. We need to be able to observe and share what our observations are about language. If somebody is repeating themselves, then we need to be able to clearly explain what's going on to the clinician. The interpreter may think their language is normal, but as a deaf interpreter, I may see that there's possibly disfluency in this person's language, or it's not typical for ASL. So what I've learned through these experiences is teaching clinicians and providers to ask the interpreter, can you please tell me exactly, or describe what that person is using? What does their language look like? Not interpret in the first person, but use what we call escort interpreting to explain to me what you're observing within their language and their expression. And if the hearing interpreter is not qualified for this, calling a deaf interpreter, a deaf consultant, to make sure that you've got that second set of eyes from a native user who's culturally and linguistically competent, you'll be able to disseminate if a person is really hearing voices or if it is something that is part of ASL culture and language. So now you can sort of conceptualize a scenario, what it looks like in deaf mental health. I'm going to tell you another scenario today. When we talk about video relay interpreting, we use the term VRI. This is not a live interpreter, but a video on screen. The patient may be in person as well as the clinician. VRI, again, is an interpreter just on a screen. On video, the deaf person would need to reference the video to see the interpreter and then to look back at the doctor or nurse or provider. I'm going to talk a little bit about personal experience here so that you can really understand the impact of this. My son ended up with croup, which is unfortunate. I had to bring him to the hospital and there was no live interpreter available. And this was a last minute urgent situation. And so having to communicate with providers at the hospital, and they arrived with VRI. And I said, okay, I have VRI today. We're going to make this work because of the urgency of the situation. Unfortunately, what happened is my stress rose when the video started to freeze. My son was quite ill. He was coughing. There was breathing issues. I was frustrated because I did not have communication with the providers to discuss my son's treatment. I was stressed and feeling frustrated. Thank God the doctor did say, you know what, hold on one moment. Let's see if we can write back and forth until we can get a live interpreter worked out. And they were very supportive in that moment and recognizing my frustration. So imagine that as a father, right, in that situation. And then those situations being exacerbated if there's a mental health factor and what that would look like. It would be a lot worse and the patient may suffer worse because of it, right? And I wonder, I'm already stressed about this situation because it's my son, it's my family. And then if we think about mental health again and how that stress can get exacerbated with communication difficulties and barriers, I would like you to think about that stress and be empathetic to that, thinking about those communication barriers for deaf individuals who are seeking treatment. Okay, so when we really think about the system and the access for deaf people, I'd like to talk about deaf children briefly, and deaf children specifically with mental illness. Dr. Vissing's, her presentation, as I sat here and listened, it was so clear to me. It really is the same for deaf and hard of hearing individuals. We need to be understanding, supportive, and pay attention. They have the additional layer of communication barriers, language difficulties, and so this can exacerbate mental illness. For example, we think about mental health with deaf children. It can be complex. We want to make sure that we are supportive, that they have communication access. Some children may be raised without exposure to sign language. They may become adults and still not have a good foundation of language. They may only communicate via gestures, basic communication. And so how do we address that? We need to bring in deaf interpreters to be able to consult, to be able to support the communication process. That child has a right to have equitable access to be able to express themselves and communicate clearly with providers so they can get appropriate treatment. I know there's only a short time today, but I want to make sure that you can clearly understand and think about some of the things that impact deaf and hard of hearing. We have a concept called language deprivation or disfluency. A person who is not exposed to language, they did not have exposure to this growing up within their family system. They may have stayed home frequently for years and years as they've gotten older, and now in their adult years, in their 30s or 40s, it may be the first time they've met or interacted with a deaf person and really see what a visual language can do or how it can work for them. What's important about that is not to assume. You need to understand a deaf person's background, where they're from. A deaf interpreter is going to be able to foster and encourage that. They may not be intellectually disabled. They may just have difficulty with expressive communication because of their background. Some individuals may need gesture. They may need to use art to express. There's a variety of different ways and tools that we can do this. Does that make sense? Okay. I'm watching the time here and being mindful. I know I only have a short bit of time, so I have a little bit more to talk about. And so now with that being said, we think about these situations. And of course, there's many more. I've only given you a few today to really think about. And so then we start to think, how can we address access for deaf and hard of hearing to the mental health care system? When we think about, providers and training them to become more aware, how do we bring in consultants, agencies to be able to hire interpreters? If you've got somebody with experience in deaf mental health, please capitalize on that opportunity. Bring the right people in. Use a collaborative approach to provide treatment. There are so many resources out there, and I absolutely encourage you to utilize them. It's important that you make sure these people have experience in mental health, and these professionals, deaf professionals specifically, reach out to them and work with them collaboratively. There are psychiatric units specifically for deaf and hard of hearing individuals, and they can support the treatment process. Okay, so there's many, many resources available to you as providers out there. On this slide, I'm going to talk a little bit about resources. The slide has resource listed at the top, and there's a list of links listed. There is a visual of a book cover that's Deaf Mental Health Care, written by Neil Glickman, and there on the bottom there's an image of a crowd of hands being raised. All right, you'll notice some websites that I've listed here. The first one is the mental health interpreter training. You might say, wait, that's just for interpreters. Why are we talking about that today? I want to share with you, many providers attend this training. Different clinical approaches are talked about. They're training on working collaboratively with interpreters. So there's many resources listed there as well. We talk about the National Association for the Deaf as another resource. They have many, many things listed on their website that would be absolutely worth it to investigate. The National Deaf Center is another place that has a lot of resources that talks about what does it mean to work with an interpreter or captioning services or VRI. One of the resources that's close to home for me is the Association of Medical Professionals with Hearing Loss. This is any provider who identifies themselves as deaf or hard of hearing or a person with hearing loss. Okay, so now you're able to really understand what a situation may look like for deaf and hard of hearing in a mental health scenario, and also some of the tips and strategies I've given you today. This last slide includes my contact information if anybody needs to reach out to me post this presentation. I want to thank you for your time and for watching my presentation. I hope that everybody has a great afternoon, and I want to say again what an honor it is to be here with you all today. Maya, I'm going to give the floor to you. I hope I kept it short and sweet today. Thank you.
It was excellent. This is Maya speaking again. Thank you so much for sharing about yourself, personal and professional experience in mental health care, scenarios explaining what healthcare for deaf and hard of hearing folks looks like, communication barriers and the dire importance of access, the ways mental health care can be made more accessible, who to contact, and resources regarding deaf mental health care. Your presentation was excellent. Okay, now mental health counselor and art therapist Allison Rabin will talk to us about the ways one can get help and current therapy practices.
Hi, everyone. My name is Allison Rabin. I am a mental health counselor and art therapist at the Artful Life in Salem. We're a group practice that does art therapy. I want to thank the Hamilton-Wenham Human Rights Commission for having me for this very important issue of the health crisis, especially in teens, that's going on right now. I have a PowerPoint. I'm looking for. Okay, I think that should do it. All right. So this is a little bit about teen mental health statistics, local groups, and hotlines that people can use for help. So this is a slide that says statistics. A lot of the other presenters also covered a bunch of this, but 1 in 5 teens suffer from at least one diagnosable mental health disorder. 50% of all lifetime cases of mental illness will develop before the age of 17. If left untreated, 50% of teens with mental health disorder will be diagnosed with co-occurring substance abuse disorder. And suicide is the second leading cause of death among teens, as Dr. Bisling also mentioned. So here is some information on hotlines that you could use either for yourself or someone else that's in need in a crisis. There's a suicide prevention lifeline, which is 1-800-273-TALK or 8255, and a couple other ones. So for resources, I wanted to tell you about the Leahy Health Behavioral Services Psychiatric Crisis Team. This is in Salem. I'm not sure if it's the closest one to Hamilton-Wenham, but if you call them, they can do a suicide assessment and figure out if you're either de-escalate or help you find a hospital that could help keep you safe. And you could also go to the hospital in Salem and they'll treat you there. But if you're in immediate danger, you should call 911. And then there's this youth at risk resource guide. It's really helpful if you're looking for resources for youth for mental health issues. They have all different kinds of therapists, programs for different populations. So I'd highly recommend that. And I'll tell you a little about my own organization, which is the Artful Life Counseling Center and Studio in Salem. So we call ourselves a place for healing, learning, and self-discovery through art. We do visual art, music, dance, drama, writing, and there's images of people doing art and Zoom group and some art on rocks. We do all different kinds of art. So we do individual therapy. So we're also licensed mental health counselors. So we combine psychotherapy with evidence-based expressive arts techniques to help individuals better process their lived experiences. In addition to individual sessions, we have groups. Right now we have one group for teens called Moving Forward, which meets at the studio on Thursdays. And it's for teens aged 12 to 17. And it's an art therapy group. So if you wanted to learn more about the Artful Life, here's the email, info@artfullifecenter.org. And we're on Facebook and Instagram at Artful Life Center. In my research of programs in the Hamilton-Wenham area, I learned about the NAN project. This is a really cool organization. It's founded by the family and friends of Nancy Kavanaugh, who's a young woman who passed away from suicide in 2012. I didn't realize it until doing the research that she actually went to Hamilton-Wenham High School. But this program promotes mental health awareness and suicide prevention programs for young people. And they use a peer-to-peer model. So like Dr. Vissing was saying, teenagers often like talking to other teenagers, and talking to adults and parents can often get in the way. So they use this peer-to-peer model. They have peer mentors tell their stories about mental health, have a question and answer, and then they sort of discuss what the best activity would be to help break the stigma in that school. So they do things like initiatives or t-shirts about breaking the stigma of mental health, fundraisers, etc. So often in schools, suicide is sort of something that's taboo and not talked about. The NAN project really wants this to be taken away and acknowledge that mental illness is a serious problem. And accepting that it's like a physical ailment, it's something that needs to be treated, and helping teens find access to services. And that is it. Thank you very much.
This is Maya again. Thank you, Allison, so much for sharing more statistics, the local groups, and giving us more insight about Artful Life's therapy and programs, which is nearby in Salem, Massachusetts, and also the NAN project located here in Hamilton-Wenham, also in Massachusetts. Finally, I'd like to introduce our last panelist, School Adjustment Counselor Katie Knudsen. She will discuss the effects that school has on mental health and how students can get counseling in school.
Hi, hoping you can hear me. Oh, and I'm supposed to, sorry, I've not done the describing my appearance, but I love that. I'm a white woman, dark, long hair, wearing a gray shirt, light background. It's nice to be with you all today. Dr. Vissing and the others covered a lot of the material that I might have shared, which works out great because I did not prepare a PowerPoint, but I'll try to think of what I can add to the discussion. So I'm a school adjustment counselor. You should know, depending on which town you live in, that my job has two different titles. In some schools, I'm a school adjustment counselor. In other schools, I'm a school social worker. I personally have been both. People who have my job either come from a counseling degree or a social work degree, but it's the same license in schools. Most of us also are licensed mental health counselors or licensed social workers. I'm a licensed mental health counselor. I work in schools. Currently, I'm working in a local public high school, not Hamilton-Wenham. I work with students who are on individualized education plans or IEPs who have counseling written into their IEP. I also work with students who are on what's called a 504 plan, which is a plan set up for a student with a documented disability who might need counseling. It could be a physical disability or a mental health disability. Lots of different things can qualify you for a 504. I also work with students in the general education population who are identified as in need of counseling. The students I work with have all of the issues that have been described: depression, anxiety, school avoidance, bipolar disorder, PTSD, various family issues or other issues, all of which have been exacerbated extremely by COVID, as has already been discussed. Kids who've been stuck at home in difficult family situations are not doing super well right now. I also work with students who identify as LGBT and might be struggling with the coming out process or with how they're being treated by peers. Also substance abusers. As part of my job, I do crisis screening if a student identifies as suicidal or in danger of self-harm. I do individual counseling. I run groups. I have in different positions worked in sub-separate programs, which is a school terminology, but a substantially separate program in a school is something that a student might be admitted to if they're on an individualized education plan and if what's working in the general education setting isn't working. So sometimes those are set up, they're called therapeutic support programs in a school for students with emotional or behavioral issues who just aren't coping in the general education environment. I also work in bridge programs, which are programs that help students return from long absences. A lot of schools have those. I know Hamilton-Wenham has one. And that might be about it. As part of my job, I do referrals for outside services. I communicate with outside providers like therapists, doctors. I am a mandated reporter, as everyone who works in a school is, but frequently that ends up being my job. If a student discloses something that looks like abuse or neglect, I need to report to the proper authorities. If a student is over 18, that's actually a different process than under 18, so I get to do both. The difference between me and an outside therapist is I am supposed to focus on removing obstacles that keep a student from being successful in the school environment. So that can look like a lot of things. It can be a lot of anxiety, sort of coping skills, relaxation, meditation, some cognitive behavioral skills, helping a student communicate with teachers or with peers if there's an issue that's come up. It can really be a lot of things, but what it is not is a full year therapy program. So I can't see students during vacations or over the summer. So if I have a student with a serious mental health issue, I'm always going to try to help them find an outside therapist. There's also certain things that students don't really want to or probably shouldn't be talking about during the school day. For example, a student who's been through serious trauma is not going to want to talk about trauma and then go back to math class. So we try to work through that sort of thing. How you get to a school adjustment counselor, a school social worker like me, you could go to your guidance counselor. Every student has a guidance counselor, or sometimes in some schools, they're now called school counselors, which gets a little confusing. And say you need to talk to someone. It could be part of an IEP process. Honestly, if you're confused about who to talk to, but you really feel like you need to see someone in school, you could pretty much go to any teacher, assistant principal, anyone, and say, how do I get to the school adjustment counselor? Depending on the school district, there could be something like 2 of me, or there could be 5 of me. So how much time we have really varies depending on the school district. I am not positive how many school adjustment counselors are at Hamilton-Wenham right now. I think maybe 3. And that's really about it for adding material, but I'm happy to take questions when we get to that point.
Yeah, this is Maya speaking. Thank you so much, Katie, for talking about your experience working with the student body, doing crisis screening, individual and group counseling, and how students can get school adjustment counselors or social workers. Now, I'd like to open up the webinar to a Q&A. You can use the raise hand function on Zoom or verbally ask your question, or privately message your questions to myself to read it out loud. Panelists, if you have any other comments or questions to ask each other, go ahead and keep your video on as well so we can easily pin you if you answer a question. I know Jesus wanted to say something else.
Yes, absolutely, Maya. Thank you. I did want to emphasize something. My presentation really just scratched the surface of deaf mental health. There is so much more that is complex about this, and I was barely able to scratch that surface today. So, I do want to encourage you, right, to explore these issues, explore them. What does it mean for a deaf person? What does it mean just to be deaf? Children, adults, etc. There are so many subcategories. And so I did want to share that with you all, that there's so much more than what I was able to share with you today.
And now if any other participants have anything else they want to add or have any other questions.
I have a question for Katie. I remember this coming up in some of our planning meetings for the webinars. Some people were wondering what happens if you go to a counselor in school for your for the duration of high school. What happens when you go to college? Like, do high school counselors help you with that? Like, what's the process there?
Yeah, so I think every college these days has a counseling center, which is wonderful. Usually students are entitled to several free sessions at a counseling center. Kind of like high school, they're not really set up for long-term counseling. So if you go to see someone at college after a few visits, they might say, you know what, I want to refer you to an outside provider who can see you long-term if that's what you need. But yeah, as part of my job, I can help you find that counseling center and connect. I have 4 kids of my own that have been through high school and into college, and know the process pretty well. It is so great to reach out to a college counseling center even before you hit campus. You can find their contact information on the school website and say, you know, how do I make an appointment with you? I'd love to make an appointment even during orientation if it feels like something you need. And how do I have an ongoing relationship with the counseling center? So as far as counseling services that are sort of mandated as part of an IEP, so if you're on an individualized education plan and have a diagnosis like depression or anxiety, and part of your IEP is to meet with me for a half hour each week, that will not apply in college. Colleges do not have to follow IEPs the way high schools do, but that does not mean you cannot access counseling services in college. It's not like the counselors in a college counseling center are going to get a list of people they have to see for a half hour each week the way I do. But I can definitely help a student, and anyone in my role can help a graduating student figure out the process in college.
I actually have another question. So Dr. Remigio, like, do you have any advice for what what other people can do to try to make mental health care more accessible, working on the outside, not being in healthcare? Do you have any guidance for that or anything?
Absolutely. That is a great question. Thank you so much. One of the important things is you need to advocate for us. As deaf people, we need advocates in our corner. Check in the healthcare system. What is it going to look like for a deaf person? Is there a video phone available? If not, is there a case manager that can come and set up that so that there is access? Is there visual alarms and lighting set up in the system? Are staff appropriately trained on how to interact with a deaf person? For example, I worked at a hospital, and so they had a video phone set up and ready. If a hearing person can access a public phone, a deaf person should be able to access that as well. When you're working with a deaf person, maybe before that happens, right? Make sure you know how to use an interpreter appropriately. You want to learn ASL, great, but learn how to work with an interpreter, learn how to interact with them appropriately. Make sure that you're meeting their needs, set up a bed alarm if they're impatient, those types of things of making sure they have visual access while they're receiving their health care. And advocating for us. Again, I can't stress that enough. We can advocate for ourselves, but if we have our hearing counterparts with us advocating, it can go so far. And again, bringing in deaf consultants to really make sure that you're providing culturally and linguistically appropriate care. And instruction, training as well. I hope that's helpful.
Yeah, that was. Thank you.
Okay, before I wrap this webinar up, is there anything else that people would like to add?
If I can add something.
Yeah, of course.
I was just thinking, everybody here who works in this field, when we think about how we can work collaboratively, especially when it comes to a specific situation, we've got children's mental health here, schools mental health, deaf and hard of hearing, and we can all work together. We don't have to stay within our specific niches. And I think it's important to remind all of us that we do have to work together for any person to be able to thrive. And that's just where I'm thinking right now as I sit here with you all.
What a wonderful note to end off the webinar on. Thank you again to all of our amazing and incredible panelists, and especially our ASL interpreters, Jody and Ashley. This webinar is part of a summer series, and if you missed the last few, you can check them out on our YouTube channel. To stay up to date on future programs, please follow us on social media at HW Human Rights. We have a pretty active Instagram account and I think Twitter and Facebook as well.
Yeah, Facebook and Instagram are most active, but yeah, any social media would be good to follow us on for updates.
And then also check out our website, hwhumanrights.org. Thanks again. Bye, everyone.